the incidence of diabetes nowadays? Not, or at least 10% of many national populations. We know some countries in which the incidence may be up to 10 or more percent. So high percent of population suffering from diabetes mellitus. Some authors consider this increase in diabetes may be related to increased levels of obesity all over the world. When we ask about the etiology, causes, still difficult issue, cannot be easily settled with every patient, but maybe a complex interaction of genetics and environmental factors. We can say that depending on the etiology of diabetes mellitus, factors sharing, contributing, affecting hyperglycemia may include reduced insulin secretion by the pancreas, decreased glucose utilization by the tissues, and increased glucose production. Many biochemical processes in the body increase the glucose production. So, three items may be sharing in this hyperglycemia, whether diminished, decreased insulin secretion by our pancreas, decreased glucose uptake utilization by tissues, and increased glucose production through many biochemical actions in our body by liver. Regarding this disease, many complications liable to occur. For example, in United States, can say that diabetes mellitus is the leading cause of end-stage renal disease, the main cause for end-stage renal disease. Also, many non-traumatic lower extremity amputations, leg amputations, foot amputations, non-traumatic, big number of cases is a complication of diabetes mellitus. Also affects the retina, eye, and diabetes mellitus is a leading cause. High incidence of adult affection of the retina and adult blindness. Also, our disease predisposes to many cardiovascular diseases. Finally, you can say that diabetes will be a leading cause of morbidity and mortality for the future foreseeable or predicted future. Many cases, pathological lesions, even mortality may be due to this diabetes mellitus and its complications. In the past, just we speak about the classification of diabetes, that it includes two main types, type 1 and type 2. Type 1 can be known as juvenile diabetes. Juvenile diabetes. Type 2 was known as adult onset diabetes. Type 1 was known as insulin dependent diabetes mellitus. Type 2 was known as non-insulin dependent diabetes mellitus. Nowadays, we can add type 3, type 4. What about this? If we have specific causes for this hyperglycemia, like drug-induced, some drugs may induce, like corticosteroid, catecholamines, may increase or initiate or induce this hyperglycemia. So we have a cause. Also, there may be non-pancreatic diseases that causes this elevation level blood glucose. If there are specific causes, we can say that this is type 3 because still in type 2, no definitive cause apparent. Type 4 related mainly to pregnancy. If this hyperglycemia occur for the first time during pregnancy, this can be known as gestational diabetes mellitus. This abnormality occur in glucose level, occur or noted for the first time during pregnancy. Mostly after delivery, everything will be okay. So we can classify diabetes mellitus into four categories: type 1, type 2, type 3, type 4. The big instance related to type 1 and type 2. So we can have an idea about this simple comparison between type 1 and the type 2 to differentiate well and to have an idea about the prognosis, the medications. Regarding the age of onset, in type 1, almost always less than 30 years old, may be discovered so early at the age of 3 years, 2 years, 5 years, like this, maybe after 10 years, 20 years. So, in general, if this case is discovered before 30 years, it is type 1. Type 2, mostly after 30 or even 40 years old. This is regarding the age of onset. Regarding the level of insulin, almost always you know that the islets, glands in pancreas of these diabetic patients is not good, not okay, not secreting insulin in sufficient amount. But what about the difference between type 1 and type 2? Type 1, there may be severe insulin deficiency, atrophy of islets of pancreas, of cells secreting insulin. It is severe insulin deficiency. So type 1 almost always insulin dependent diabetes. No management without insulin. In type 2, the insulin deficiency may be mild, maybe moderate, maybe more variable, variable. But for long time, control may be without insulin, maybe with oral hypoglycemics. Regarding the ketosis, in type 1 common to occur, and it is severe, marked, absent in the type 2. The antibodies, known islet cell antibodies present in type 1, diabetes mellitus, but absent in type 2, diabetes mellitus. The patient, regarding body weight, mostly in type 1, the patients are non-obese, but the big percent in type 2 is obese, maybe 85%. This will help you to diagnose type 2 diabetes mellitus. Again, what about insulin? It is essential in type 1. It is a must to treat your patient with insulin. It is insulin dependent diabetes. But in type 2, we start by oral hypoglycemics and may be sufficient for a long time. So, not necessary to have insulin as the main line of treatment for type 2 diabetes mellitus. Regarding the symptoms or simple diagnosis for diabetes mellitus, our patients may have some symptoms like polyuria, especially sometimes nocturia. For the patient, say for the doctor, almost always when I go to sleep, I begin to go to the WC. No need. But after some time, When I feel that there is a problem, I have nocturia. Go to the toilet maybe more than one time, which is a recent event for this patient. Also, he needs more and more water. Thirst sensation almost always, polydipsia, water intake so much. He eat also much, but the weight going to decrease, weight loss, polyphagia and weight loss. Ketoacidosis, as we speak about it, may be the presentation of type 1. As to say, sometimes difficult to diagnose this diabetes mellitus in type 1. But suddenly, we have a big problem associated with ketoacidosis and high level of hyperglycemia. Sometimes the diagnosis occurs at these situations. But in type 2, the case may be completely asymptomatic. No polyuria, no polydipsia, no polyphagia. Sometimes maybe like this. So when we are suspecting a case of diabetes, we must check up by doing the blood glucose level in order to diagnose if we have fasting plasma glucose concentration more than 126 milligram percent on at least 2 or more separate occasions. This may start to diagnose this diabetes. Sometimes we are need for doing what is known as oral glucose tolerance test, glucose tolerance curve, in order to take many samples, blood samples, and to diagnose the blood glucose at different points after eating, not only after 2 hours, but maybe half hour, 1 hour, 1.5, like this. This curve may help us in the diagnosis because if the diagnosis is established, we must have lines of treatment so early in order to minimize the complications of this disease. Till now, is it clear, our students?
Yes,
Yes. Regarding the treatment of diabetes, we may have 3 main lines of treatment. Diet regime. Diet regime. This is sometimes may be sufficient if the blood glucose level or hyperglycemia is not so much. And the case is so early, sometimes diet alone may be sufficient to control. This depends on the follow-up, check-up, my blood glucose. Number 2, in cases of type 2 diabetes mellitus, oral hypoglycemic drugs, also in addition to diet control. Number 3, especially in type 1, which is insulin-dependent diabetes, we need insulin preparations in addition to diet regime, diet control. What about this diet? What is related to diet as a line of treatment for diabetes? The main principles related to diet include measuring, calculating total caloric intake, the total number of calories needed by this patient, and also the dietary composition. Not to say for your patient you are in need for 3,000 calories per day. You can eat as you know. I must give him some details about the composition of this diet. Not all the diet to be fatty. Not all the diet of, or most of it to be carbohydrate. No. So the dietary composition is also important in addition to measuring the total caloric intake or total number of calories needed by the patient. On what base we measure these total calories and say this patient in need for 2,500 calories. Other patient needs 3,000. On what basis? On the age, on the body weight, and the physical activity. For example, if you have two adult onset diabetes patients, one working as officer, office work, all the day he is sitting, no physical activities, and another patient working as a builder. It is the same. Both the officer and the builder may need the total number of calories, or it must be different. What is your response, your answer?
Must be different.
Yes, must
Different.
be different. When I need more calories, with the builder or with the officer?
Boy, the
Yes, yes. We can say that in general, those patients with about 85% or more obese in type 2, we give our advice to weight reduction by caloric restriction. This may help us to control the hyperglycemia. So almost always we put obesity as a risk factor, as a complication for diabetes. The case will not be simple if there is obesity in addition to our diabetes mellitus. Insulin resistance may occur later due to this obesity. So from the start, if my patient is obese, I must be cautious to advise. I must advise him to do caloric restriction in order to allow weight reduction. This will help me well in controlling hyperglycemia. Patient with type 1 diabetes, very rare to find them obese, very rare. So your main goal in this type 1 diabetes is to maintain adequate development in children. This child may be 3, 4, 5 years, 10 years, still there is growth and development in the early childhood. I must be sure that diabetes not interfere with this normal process, physiological process of growth and development. This is my goal in type 1. Not only to control the level, and now he is euglycemic, not hyperglycemic. I must be sure that growth and development is okay for this patient. This is regarding to the calories needed by the patient. It depends on many factors like physical activity, age, and the body weight. But what about the composition? The patient may be in contact with team of uh, health care professionals, not only doctor of diabetes, but also dietetic management important. He must take example about this diet. Very easy to say for him, you can better to take 3,000 calories, but about the composition, he must be, he must know very well that the diet composition include carbohydrates with a percent about 50% or 60% of the total caloric intake. Fats not more than 30% of the total caloric intake. Proteins about 20% of the total caloric intake. The composition of calories must be like this. And I must give an example for this carbohydrate. May include bread, loaves, rice, something like that, sweets. All these must be given as example. What about the amount of all of these? Because mostly you must not exceed this level of calories through the carbohydrates, 50%, for example. Our advice regarding the diet, we focus on dietary fibers. What are dietary fibers? They are plant components which are indigestible by humans and can be classified into two types. Dietary fibers can be classified into two types. One type is soluble fiber, the other type is insoluble fibers, cellulose. Soluble fibers, for example, gums, pectins, found in vegetables, especially leafy vegetables, fruits, beans, like this. This is soluble fibers. Insoluble fibers like cellulose, which is found in bread. Some vegetables also may contain significant amount of this cellulose. Foods with relatively high soluble fibers content tend to slow glucose absorption. They tend to slow glucose absorption, so hyperglycemia start to be controlled, start to be decreased. Also, this type of foods may decrease the blood cholesterol. In order to well managing this diabetes, I must be cautious for controlling hyperglycemia, for controlling blood pressure, for controlling the blood level of cholesterol and the lipids. All these must be managed at the same time in order to decrease the possible complications of this diabetes mellitus or of this disease. Also regarding the meals, is there definitive number of meals and timing of these meals in relation to our therapy, in relation to our drugs like insulin? Yes. Number one, we can say that those patients, diabetic patients who are receiving insulins, in those patients, the meals should be adjusted to match food intake with the time course of action of insulin. Administered insulin. Why? Suppose that you neglect this advice for the patient and ask him to take morning insulin and evening insulin. My patient take morning insulin and after more than 1 hour he start to eat. In this 1 hour, he may go into hypoglycemia by the effect of insulin. Insulin has a rapid effect, especially definitive preparations, short time preparation or short duration, crystalline. So our advice for the patient, breakfast should be eaten within 1/2 hour after the morning insulin dose. Not to give him insulin without well prepared diet. Maximum 1/2 hour he must take his breakfast. Also regarding the size of meals, many populations have only 3 diets per day: breakfast, lunch, and dinner. For a diabetic patient, the total caloric intake must be distributed over 3 main meals and 3 snacks. Total will be 6 times. This is better for the distribution of calories intake all over the day. The patient must have breakfast and after some time, mid-morning snack. Patient must have lunch and after some time, mid-afternoon snack. Dinner and bedtime snack. By bedtime, in order not to allow this patient to be on the hypoglycemic side. Better, as a rule, in treatment of diabetes mellitus, especially who are using insulin, better to put your patient on the hypoglycemic level than to put him on the possible hypoglycemic level. Hypoglycemia during sleep may be fatal. So we have also after dinner bedtime snack. This is the whole story related to the diet. What about drugs for adult onset diabetes? We have the Victor oral hypoglycemic drugs. Many times in general pharmacology, we speak about oral hypoglycemic drugs. Who can remember uh, oral hypoglycemic drugs related to pharmacokinetics, related to distribution, related to plasma protein bound? Who can remember? Is this group of oral hypoglycemics has tendency to be bound to plasma protein in high amounts or no tendency? Who can remember? Oral hypoglycemics, oral contraceptives, oral,
اللي
yes, these oral preparations have tendency for plasma protein bound or not? Yes, all oral hypoglycemic, oral anticoagulants, oral contraceptives, three oral in medicine have this tendency. Regarding the oral hypoglycemics, we have a big group known as sulfonylureas. It is the oldest group. These sulfonylureas nowadays can be classified into two generations. Old generation known as first generation and more recent generation known as second generation. Oral first generation, our example is tolbutamide, old drug, tolbutamide. This drug nowadays not to be used. Why? Most of these first generation drugs have short plasma half-life. So they must be given by multiple doses throughout the day. This is a big disadvantage for compliance. I need easy administration, drug to be taken once or maximum twice per day for better compliance. So, as tolbutamide and other examples for first generation needed to be taken more than 1 or 2 times per day, not favorable nowadays to give these drugs. Second generation, I have many examples like glibenclamide, may have a trade name in the pharmacy as Dawanil. Dawanil. Glibenclamide, glyclazide also have a trade name diamicron with different doses. And I have glimepiride, known as the trade name Amaril. So I have many examples. Some example for second generation, glibenclamide, glyclazide, glimepiride. We can say that these drugs may be given once daily. Glimepiride, for example, is most important and the lowest dose of the sulfonyl urea. This second generation, more potent, not only to be given for as one time or maximum twice per day. No, more potent than first generation and well tolerated by the patient, less side effects sometimes, and better compliance. My patient, if I give him once per day treatment, almost always he will take this treatment regularly, not to be forgotten. But when I say for him, he will take this drug 3 times or more per day, sometimes he may neglect. Also, fewer drug-drug interactions related to this group. because we speak about sulfonylurea or oral hypoglycemic as a drugs which have tendency for plasma protein bound. This means many drug-drug interactions may occur due to displacement of plasma proteins. In case of second generation, these drug-drug interactions will be minimum, will be fewer. What is the indication of this sulfonylurea? Treatment of type 2 diabetes. Type 1 cannot be managed by oral hypoglycemic study because I have severe deficiency of insulin and the replacement by insulin must be. So the main indication is treatment of type 2 diabetes mellitus. This sulfonylurea, like glybenclamide, glycoside, how to? What about the possible mechanism of action? We can do a simple classification for oral hypoglycemics. Like what? Based on this mechanism of action, we can say that I have insulin secretagogues. Let's say drugs which help or promote the release of insulin from pancreatic beta cells. I know that my pancreas is not atrophied, but it may not give me sufficient amount of insulin, so I have hyperglycemia. My drug like sulfonylurea may act through promoting release of insulin from beta cells. So I can say that this group can be classified as insulin secretagogues. Insulin secretagogues. Another mechanism of action of this insulin secretagogue or sulfonylurea, reduction of serum glucagon. We know that almost always insulin and the glucagon have opposite mechanism of action. Glucagon tend to produce hyperglycemia. Also, my sulfonylurea group of drugs potentiate the action of insulins on its target tissue. So, sulfonylurea may have three mechanisms of action. One is promoting the release of insulin from beta cells. Second is a reduction of serum glucagon. Third, potentiation of the action of insulin on the target tissues. As we have said that many side effects or adverse reactions may occur with this group of oral hypoglycemic sulfonylurea. Number one, hypoglycemia liable to occur, particularly in elderly patients. So I must be meticulous, cautious regarding the dose. Sometimes I need only one half tablet, not to be one tablet, because hypoglycemia may be sometimes fatal. Almost always I must be cautious regarding these side effects of hypoglycemia. Especially it occur in old age with impaired hepatic or renal function who are taking long-acting sulfonylurea. What is the problem related to impaired liver and kidney function? Why? In these cases, with impaired hepatic or renal function, the liability for hypoglycemia may be more. In this old age, sometimes the liver function is not good, kidney function is not good. So the elimination of my drug will not be good. And my drug may be sustained for long duration in the body and allow the overdose effect. When my drug not to be eliminated, the case will be like overdose or toxic dose. So hypoglycemia may occur. Also, in case of renal function, disturbed renal function, the elimination will be decreased, and I have over effect of the drug. So hypoglycemia may occur so easily. This is the most risky side effect. Gastrointestinal upsets, colic, vomiting, diarrhea, anything like this may occur in some of these drugs. Jaundice may occur. Allergy, like any drug, may cause allergic skin rashes. Hematological reactions affecting the bone marrow may be not so common, but I must have an idea that a granulocytosis